I'm Dr. Fakir Ovari, and this is Pharmacokinetics and Pharmacodynamics of Vancomycin in adults. The first learning objective is explain the pharmacologic, pharmacokinetic, and pharmacodynamic properties of vancomycin. Vancomycin is a giant molecule. It is a tricyclic glycopeptide. It binds to the D-allo residue of the pentapeptide cell wall building block and therefore inhibits cell wall synthesis, resulting in bactericidal activity that's relatively slow when you compare it to beta-lactams. For the most part, the activity of vancomycin is against gram-positive organisms. So gram-positive organisms such as streptococci, enterococci, with the exception of vancomycin-resistant enterococcus, methicillin-susceptible staphylococcus aureus, as well as methicillin-resistant staphylococcus or MRSA. Vancomycin does not have activity against any gram-negative organisms, as well as it does not have activity against anaerobic organisms such as Bacteroides. It also does not have activity against any of the atypical bacteria. As I mentioned, vancomycin binds to the D-allo residue of the peptidoglycan layer, and therefore it inhibits formation of peptidoglycan layer. As you can see in gram-negatives, there is an outer membrane above the peptidoglycan layer, and vancomycin is a huge molecule, and because it's a huge molecule, it cannot go through the outer membrane of the gram-negative organisms, and therefore it cannot touch the peptidoglycan layer in gram-negatives. Therefore, vancomycin does not have activity against any gram-negative organism. It only has activity against gram-positive organisms. Here's what the peptidoglycan looks like. Note that this is a mesh of basically building blocks of the peptidoglycan. Those building blocks are basically G and M. So N-acetylglucosamine and N-acetylmuramic acid. And the way that this peptidoglycan mesh is formed is that these building blocks will actually cross-link with each other, and overall it will create this mesh. And what vancomycin does is that vancomycin will actually bind to these building blocks, and when it binds to these building blocks, it actually inhibits cross-linking. So because there will be no cross-linking, because vancomycin inhibits that, then there will be no peptidoglycan layer formed. Let's take a look at vancomycin pharmacokinetics. Vancomycin oral absorption is negligible. So therefore, if you administer vancomycin orally, it will stay in the GI tract. It will not be systemically absorbed. Sometimes this is a good thing. For example, if you're treating Clostridioides difficile infection in the colon, we actually give oral vancomycin, and it's good that it actually stays in the GI for that infection specifically, because the site of infection is in the GI. For all other infections, oral vancomycin has no role. So vancomycin, for all other indications, it needs to be administered intravenously. For the most part, vancomycin pharmacokinetics shows a lot of variability in different patient population, including protein binding and volume of distribution. It is renally excreted for the most part, so renal function is very important when it comes to vancomycin therapeutic drug monitoring, just like aminoglycosides. And the half-life of vancomycin in someone with normal renal function is about 4 to 6 hours, and it will be extensively prolonged in someone with renal dysfunction. Before we talk about vancomycin, it's important to understand two-compartment pharmacokinetic model. So in the one-compartment model, you basically administer the antibiotic and it will stay in the central compartment. One-compartment model is very straightforward, so you can do the kinetics very easily. Because aminoglycosides are hydrophilic, their pharmacokinetics are very close to one-compartment model. So for simplicity, you can assume that aminoglycosides show one compartment model. Although vancomycin is also hydrophilic, it actually has the ability to distribute into tissues. So it can actually penetrate different tissues. Therefore, vancomycin shows a two-compartment model. So one compartment is the central compartment, which is basically circulation. And then the second compartment is when vancomycin goes from the central compartment to the periphery tissue. So the periphery tissue is that second compartment. This is significant because as we administer vancomycin intravenously, it goes into the central compartment, which is circulation, and normally it will be eliminated through the kidneys. But however, because it's also penetrating into the peripheral tissue, there is also the distribution phase. So when you give vancomycin initially, the peak will be very high, and then during the distribution phase, the levels drop very quickly, and then it kind of slows down during the elimination phase. This becomes extremely important when we decide when to get our levels. So we want to avoid getting level into the distribution phase, which typically takes about 2 hours. CLSI is the Clinical Laboratory Standardization Institute, which is the organization that sets standards for laboratories, including microbiology laboratory. So in this table, we're looking at the susceptibility breakpoints. Breakpoints basically are the points that we use to interpret MICs. So when we get a vancomycin MIC for a specific organism, MIC is just a number. We should be able to interpret, for example, if we say the MIC is 1, we need to be able to interpret it as, what does that 1 mean? Does that mean it's susceptible, intermediate, or resistant? And these breakpoints depend on the organism. So for Staphylococcus aureus, which is the number 1 reason for using vancomycin, the susceptibility breakpoint is set at 2. So an MIC of 2 or less is considered susceptible. So for example, if we send a sample to the micro lab and they determine that the MIC is 0.5 for Staphylococcus aureus, then we would say that because it's less than or equal to 2, it's considered susceptible. Whereas if that MIC comes back from the lab and it's actually 4, then we say, well, 4 and 8 are actually considered intermediate. So that's how you would interpret it. For coagulase negative Staphylococcus, the breakpoints are actually higher, so an MIC of 4 or less is considered susceptible. The same is true for Enterococcus species, so MIC of 4 or less is considered susceptible. For Streptococcus, the breakpoint is actually 1 or less. And these are the latest 2019 CLSI breakpoints, and these numbers get updated annually. And these numbers haven't changed in years, so it's unlikely that they will change next year. So these are the 3 common PK/PD indices. So we have peak to MIC ratio, AUC to MIC ratio, and time above MIC. For vancomycin specifically, AUC to MIC is the PK/PD target most associated with efficacy. So AUC to MIC is the index that we use for vancomycin. However, you want to achieve a specific number. So for Staphylococcus aureus specifically, we want an AUC to MIC ratio of 400 to 600. So you want it to be at least 400. You also don't want it to be too high because of toxicity issues. So ideally between 400 to 600 is recommended by the 2011 IDSA guideline, as well as the 2020 ASHP IDSA guidelines for therapeutic monitoring of vancomycin, which were finally published earlier in January of 2020. And then there are different methods to actually measure MIC. So these numbers are based on the broth macro dilution reference method of getting MIC. And the AUC is ideally in this for a 24-hour period. So from the time of initiation of vancomycin up to 24-hour period. So that's the area under the concentration curve that we would calculate. Now, historically, it has not been practical to calculate AUC. So what a lot of guidelines have done, they have used trough as a surrogate for AUC to MIC. Especially that 2011 guideline used trough as a surrogate for AUC to MIC. So as you see different guidelines for different infections, they, instead of AUC to MIC target of 400 to 600, a lot of these older guidelines actually have trough targets. So they would say for severe infections, a trough target of 15 to 20, and for less severe infections, such as diabetic foot infection, 10 to 15. However, the 2020 guidelines actually do not recommend targeting a trough. They actually recommend targeting AUC to MIC of 400 to 600. However, it is important to note that these guidelines only make recommendations for severe infections. They don't make any recommendations for non-severe infections because of insufficient evidence. But it's important for you to know that there are a lot of guidelines out there, specifically older guidelines, that are targeting troughs. And most hospitals in the US are actually following these targets. So you need to know all these targets because any hospital that you go to, they may be targeting these numbers, so you should be familiar with them. In the future, it's likely that hospitals will slowly start to transition to targeting AUC to MIC of 400 to 600 for Staphylococcus aureus specifically. We looked at the PK/PD of vancomycin. Now the next learning objective is determine a vancomycin loading dose for critically ill patients with serious MRSA infections. What is steady state? Steady state is the point at which the rate of drug administration is equal to the rate of drug elimination and the concentration of drug is constant. Now, steady state is based on the drug's half-life and it occurs after approximately 4 to 5 half-lives. Steady state is the most optimal time for obtaining vancomycin levels. So if you're gonna target trough, it's best to get it during steady state. Otherwise, you end up overdosing vancomycin because if you get the trough during this time, it's going to be subtherapeutic. On the other hand, before reaching steady state, there will be subtherapeutic levels of vancomycin. So we don't really want to decide our maintenance dose based on levels in the period of time before steady state, because if you decide the maintenance dose here, once the drug gets to steady state, you're gonna be overdosing vancomycin. So you want to get the levels during steady state. On the other hand, this raises an issue that before we get to steady state, we will actually be underdosing vancomycin. So one way to battle this is to actually give a loading dose. So the red graph shows you what happens without the loading dose. So it takes some time for the levels to rise up to steady state, which means that during the initial period, there will be subtherapeutic levels of the drug. By giving a loading dose, you quickly achieve a high dose. It will eliminate any subtherapeutic period of time, and then it will help you to get to that steady state faster without affecting the maintenance dose. So here's what the guidelines recommend for a loading dose. So it's only recommended in seriously ill patients. So patients with sepsis, meningitis, bacteremia, infective endocarditis, pneumonia, and osteomyelitis. And of course, only these infections if they're suspected to be due to MRSA infection. So if other organisms are causing this, these recommendations do not apply. But if MRSA is suspected in these infections, then a loading dose of 25 to 30 milligram per kilogram is recommended based on the total body weight dose. Now, because the loading dose are larger doses than the maintenance dose, it has the potential of causing reactions. So typically histamine reactions, so if that happens, we can use antihistamines in patients. We can also increase the infusion time. So if you infuse it over 2 hours, and I'll explain that more on the next slide. Loading doses are also helpful in patients who have creatine clearance less than 60, because the half-life is longer in these patients, so it actually takes longer for these patients to get steady state. So if someone has renal dysfunction, it will actually take a very long time for them to get to steady state, because steady state typically is 4 to 5 times the half-life. So if the half-life is longer in these patients, it takes even very longer to get to steady state. So these patients will also benefit from a loading dose. So the first part is recommending loading dose for serious infections. This part is recommending for any infections in renal dysfunction. And they're saying do not exceed a single loading dose of 3,000 milligram or 3 gram because of those histamine related reactions. Now, we currently don't have clinical evidence that giving a loading dose actually makes a difference on mortality. It does make sense from a pharmacokinetic perspective that it can optimize the dosing in patients. So the 2011 IDSA guidelines for MRSA infections, they actually made a recommendation for seriously ill patients. And these are those who have sepsis, meningitis, bacteremia, infective endocarditis, pneumonia, and osteomyelitis. And for these patients, they recommended that a loading dose may be considered. So pay attention to the language. When they say may be considered, it means that it makes sense to do it. But, if you were to not do it, you're technically not denying the patient of life-saving intervention. Now, they recommended a dose of 25 to 30 milligram per kilo using total body weight. And because this is a large dose, you're going to end up with a large dose that puts the patient at risk of infusion-related reaction, specifically red man syndrome, which I will discuss shortly. So they do recommend to extend the infusion time to 2 hours. and also use antihistamines prophylactically in order to reduce the risk of having red man syndrome. And typically we use diphenhydramine 10 to 50 milligram, either IV or IM, to prevent red man syndrome. Now, in the new 2020 ASHP IDSA guidelines for therapeutic monitoring of vancomycin said that in critically ill patients with suspected or documented serious MRSA, and serious MRSA infection, basically the same types of infection that were listed above, and they actually give a wider range of dosing, so 20 to 35 milligram per kilo of total body weight, and they increase the range basically to allow better use of your judgment, so you can decide based on different characteristics of your patient which one would be more appropriate. And again, the languages can be considered, so it's not that you have to do it, but it makes sense to give this to patients with critical illness because they are at increased risk of mortality. Now, in obese patients, they do recommend a smaller dose of 20 to 25 milligram, and regardless of whether the patient is obese or not, the loading dose should not exceed 3000 milligram or 3 grams. And the most common infusion-related reaction is red man syndrome. So red man syndrome is histamine-mediated hypersensitivity. As you can see in this picture, it actually causes flushing, erythematous rash. It causes some pruritus, and sometimes mild to profound hypotension, including even cardiac arrest, which is not as common. And this can be avoided if you slow the infusion rate. Typically, if you reduce it to about 15 milligram per minute. And there are also standardized recommendations. So if you're, you don't want to infuse anything less than 1 hour. So the infusion time for vancomycin should be at least 1 hour. And then the higher the dose, you can actually prolong it. So for anything, if it's 500 milligram or 1000 milligram, you typically infuse over 1 hour. So a 500 milligram over 1 hour, it's about 8.3 milligram per minute, and then 1000 milligram infused over 1 hour is about 16.6 milligram per minute, which is almost around 15 milligram per minute. It's not too much higher than 15 milligram. So most people will tolerate 1000 milligram over 1 hour. If they start to have reaction, what we can do is to increase the infusion time to 90 minutes and potentially 2 hours. And then 1250 milligram is recommended to do a 90-minute infusion. The same with 1500 milligram. So again, 1250 over 1.5 hour translates into 13.8 milligram per minute. And 1500 milligram over 1.5 hour is about 16.6 milligram per minute. 1750 milligram is recommended to be infused over 2 hours, which is about 14.6 milligram per minute. And 2 grams are recommended to be infused over two hours, which is about 16.6 milligram per minute. Of course, you can infuse any of these even longer if the patient was not tolerating it. So for example, I have done 1000 milligram over 3 hours in patients before, just because they weren't tolerating it. And of course, you can also administer diphenhydramine to these patients to reduce the amount of this reaction. Most patients, however, will not experience it. So most patients actually tolerate vancomycin very well. We looked at PK/PD of vancomycin and determined the vancomycin loading dose for critically ill patients with serious MRSA infections. Now the next learning objective is, given a patient with a suspected MRSA infection, recommend IDSA guideline-concordant empiric vancomycin maintenance dose and frequency. These recommendations are from the 2011 IDSA MRSA guidelines, and these are intended to make recommendations more straightforward, and they do not depend on pharmacokinetic equations. So there are no equations involved when you recommend a vancomycin dose following these recommendations from IDSA. So basically they recommend that for IV vancomycin, you can use between 15 to 20 milligram per kilogram per dose, and that's using total body weight as the body weight. So once you determine the dose, then you determine the frequency. That's typically every 8 to 12 hours in patients with normal renal function. And they recommend not to exceed 2 grams per dose. So if someone is obese, they recommend not to exceed 2 grams per dose in order to avoid the nephrotoxicity. And then they recommend to get the trough prior to the 4th or the 5th dose. And then once you get that level after, or I should say prior to the 4th or the 5th dose, they recommend to a target trough of 15 to 20. So the higher end of the trough, 15 to 20, for serious infections such as bacteremia, endocarditis, osteomyelitis, meningitis, pneumonia, and severe skin and soft tissue infections such as necrotizing fasciitis. And of course, any of these, as long as they are due to MRSA. And so, you know, anytime you use the 15 to 20 milligram per kilo, most hospitals round to the nearest 250 milligram. So for example, if you calculate 300 milligram, you're going to round it to 250 milligram. Or if you, you know, calculated it to be 1,200 milligram, you round it to 1250. So whatever is the closest next 250 milligrams. So these are estimation, and then you will find out if this was the right dose or not prior to the 4th or the 5th dose. You know, and the reason they recommend prior to the 4th or the 5th dose, that's the closest to the steady state. So they want you to adjust the dose based on the level from steady state, because if you get the level too soon, it's gonna be subtherapeutic, so you're gonna increase the dose, and then by the time level is at steady state, it will be supratherapeutic, and then the dose will be too high. And then the way you can choose the frequency is based on renal function. So in someone with excellent renal function, meaning creatinine clearance greater than 90, you can actually do every 8 hours. And of course, these recommendations are in adults. And then in patients with creatinine clearance of 50 to 90, you can do every 12 hours because it takes longer for them to clear it. Unless if they weigh actually more than 100 kilo, then you can do every 8 hours to keep those daily doses smaller. With creatinine clearance 15 to 49 every 24 hours. And then with you know, end-stage renal disease, you actually want to do PRN, or I should say as needed dosing. And what that means is that you actually give a single dose and you don't give it the frequency. You just say it's as needed, and you just check a random vancomycin level in 24 hours after the dose, and then if the level is less than 20, then you give one more dose, and then you keep doing this every day. Whereas if the next day, you know, because the kidneys are not clearing it, if the level is more than 20, you actually hold the dose and you repeat the random level in 12 hours. Now, this is one way of doing it. Most hospitals actually have protocols on how to approach this. So you may, depending on what hospital you work at, you may see a protocol that's slightly different than this. But generally speaking, you know, these protocols do PRN dosing of vancomycin in end-stage renal disease. With dialysis, is also PRN dosing, because on certain days where hemodialysis is not done, on those days, chances are that the level will be greater than 20, and you just hold the dose until the day that they get dialysis. And I'll explain more about hemodialysis in a little bit. Now, in the 2020 ASHP IDSA vancomycin guideline, basically they make the same recommendation of 15 to 20 milligram per kilo per dose using total body weight every 8 to 12 hours in patients with normal renal function. And they do say that trough only monitoring with a target of 15-20 is no longer recommended. They say that the most accurate and optimal way to manage vancomycin dosing should be through AUC guided dosing and monitoring, specifically targeting individualized AUC to MIC ratio of 400 to 600. And this is empirically, since it takes some time for MICs to come back, empirically we just assume an MIC of 1, because for the most part, more than 90% of MICs in the United States are either 1 or less. So it's unlikely to have MIC of higher than 2. And then of course, if we get the MIC of 2, we actually will not be able to achieve these targets using the traditional dosing of 15 to 20 milligram. Now, for the monitoring, they recommend that vancomycin targeted exposure should be achieved early during the course of therapy, preferably within the first 1 to 2 days. And we will cover more details of how to monitor AUC to MIC in learning objective number 7. We explained the PK/PD of vancomycin and determined the loading dose in critically ill patients. We also determined IDSA, guideline-concordant empiric vancomycin therapy. Now the next learning objective is given a patient with a suspected MRSA infection, determine an empiric vancomycin maintenance dose and frequency based on population pharmacokinetics. So when it comes to population kinetics, the purpose is, of course, is to determine dosing regimen of vancomycin based on therapeutic targets and population parameters. So we're making assumptions from these models, from these pharmacokinetic models. The first assumption is that whoever the patient is, it actually fits the population parameters. And of course, we're making assumption that the patient is not on dialysis and the patient is not volume overloaded. So some examples of exceptions to population kinetics includes end-stage renal disease. So these population kinetics don't apply to end-stage renal disease. They also don't apply to heart failure exacerbation. They do not apply to anosarca, which basically means volume overload in the entire body. Ascites, which happens in patients with cirrhosis, so that's also fluid retention, and cystic fibrosis. So all of these affect fluid status of the patients, which affects vancomycin volume of distribution. So, when it comes to population kinetic, of course we have the population. The problem is these models are basically derived from a sample of the population. So a group of patients are selected in a study, and then in the study, they come up with a pharmacokinetics model, and that pharmacokinetics model, of course, applies to that sample of patients, but the question is, does it apply to the rest of the population? So we have to be very careful when we use population pharmacokinetics. So one of the equations that's from population is vancomycin clearance. So vancomycin is actually eliminated primarily by the kidneys, and its clearance is correlated with patients' creatinine clearance. So about 70 to 90% of the creatinine clearance is actually vancomycin clearance. So we can actually use this equation that vancomycin clearance in liters per hour equals 0.8 times creatinine clearance, as long as creatinine clearance is in liters per hour units. And in order to get creatinine clearance in liters per hour unit, you basically multiply the creatinine clearance that you normally calculate from Cockcroft-Gault, you multiply it by 0.06, that gives you liters per hour, and then you multiply that by 0.8 to get vancomycin clearance. Now, of course, there are many other equations for vancomycin clearance. This is the equation that we're going to use in this class. So, other equations are also valid. So you may see preceptors who use different equation, and that's okay. The next equation is volume of distribution. Volume of distribution, although vancomycin is hydrophilic, it has a huge variability in volume of distribution. It goes from 0.4 to 1.0 liters per kilogram. And because it's hydrophilic, volume status makes a difference. So if someone who's dehydrated, the volume of distribution is lower. So it's closer to 0.4 liter per kilogram. Whereas in someone with fluid overload, because the volume of distribution would be higher, it's actually closer to 0.9 or 1.0 liter per kilogram. Now, the volume of distribution also depends on gender, age, weight, and renal function. So females, elderly, and obese patients actually have higher volume of distribution. And the lower the creatinine clearance, the higher the volume of distribution. So for most patients, we will use the volume of distribution in liters equals 0.7 liters per kilogram times total body weight in kilogram. However, this equation, you should only use it in patients with normal volume status. So if you've given a case, if the patient has normal volume status, you can use this. Whereas if someone is dehydrated, you should use something closer to 0.4. And if they have fluid overload like congestive heart failure, you should use something closer to 1. And again, there are many other equations for volume of distribution. There is no perfect equation. In this class, we will use this equation. You may work with preceptors who use different equations, and that's okay. So elimination constant. We actually are going to use the Motzky equation in this class. So this was derived from population kinetics, which is basically 0.00083 times creatinine clearance, this time in milliliters per minute. And then once you multiply that, you add 0.0044 to it, and it will give you K in inverse hours. And then of course you can use K to calculate half-life. And then you calculate tau. So for tau, you want to use your target peak and trough. Based on the infection, IDSA has recommendations of what your goal trough should be. So you either have a target trough of 10 to 15 for non-severe infections, or you have a target of 15 to 20 for severe infections. So you pick something in the middle. So if your target is 10 to 15, you can choose either 12 or 13 and put it in the trough. If your goal is 15 to 20, you can choose something like 16 or 17 here. And then for the peak, if you have the lower target trough, you can choose 30, and if you're and put it in here. And then if your target trough is 15 to 20, you can choose 40 and put it here. And it really doesn't matter what you pick for the peak. It's just to give you a more realistic tau number. And so once you calculate tau, you want to round it to something that's clinically meaningful. So for most people, Q8 and Q12 will be the the actual tau, as long as they have normal renal function. If they have renal dysfunction, you need to use even longer frequency. And some patients may actually need Q6. If you get a single dose that's too high, so more than 2 grams, you may actually give a smaller dose but more frequency in order to achieve the same daily dose. And then once you get the tau, then you actually calculate the dose that you want. And again, you use the same kind of peak based on your target trough in this equation. So this is the target peak that you want. And then once you get a dose and frequency, before you recommend it, but first of all, you want to round your dose to the nearest 250 milligram. But before you recommend your dose and frequency, you actually want to verify to see what would be the predicted peak and trough. You want to make sure that the predicted trough is the actual goal trough that you want. So you basically use these two equations to get that. Now, one thing that's different between vancomycin and aminoglycoside is that when you use the equation for dose, for the time of infusion, you put 1 initially because you have no idea what your dose is. So initially you just plug in 1 just to get the number. But once you actually calculate the dose, when you verify your peak and trough, for the time of infusion, you want to use the time of infusion that matches your dose. So for example, if you calculate the dose to be 2000 milligram, you want to use a time of infusion of 2. And that's because for vancomycin, you have to use the right time of infusion in order to avoid red man syndrome. We explained the PK/PD of vancomycin and determined the vancomycin loading dose. We also recommended IDSA guideline-concordant empiric vancomycin maintenance dose and frequency. We also determined empiric vancomycin dose and frequency based on population pharmacokinetics. Now the next learning objective is, given a patient with an MRSA infection, select an individualized vancomycin dose and frequency based on serum vancomycin level. Most hospitals in the US get a single vancomycin level, typically a trough level. So first, let's examine how to adjust the dose based on a single vancomycin level. Anytime you have a level back and you're about to assess the dose, first and foremost, you need to reassess the patient's renal function to make sure the renal function is stable. Because depending on what's going to happen with the renal function, that could affect how you're going to adjust the dose and frequency. Then you need to assess the level. So when you order a trough, you shouldn't always assume that it's actually a trough. So when you order a trough, it's just a matter of when the nurse actually draws the level. So when the level comes back, even though it's labeled as a trough, you should assess the time that it was drawn to make sure that it was actually a true trough. Once you establish that the level was actually a trough, then you can actually use a simple proportion to estimate how to adjust the dose. And this equation of proportions only works with total daily dose. For example, if somebody was receiving 1 gram Q8, then the total daily dose would be 3 grams. So you would put 3000 milligram here, and then you would put here the actual level that came back as a trough, assuming that the measured trough was not at goal, because if it was at goal, then you shouldn't change the dose. But if it was not at the target trough, then you need to adjust the dose. So then here you would put the goal trough and then solve for X, and X would give you the total daily dose. You can use this equation with either subtherapeutic levels or with supratherapeutic levels. So if it's a subtherapeutic level, ideally you're going to increase the daily dose. If it's supratherapeutic, you're going to decrease it. And then whatever total daily dose that you get, then you will have to convert it to the same frequency. So for example, if somebody was receiving 1 gram Q8 and you converted that to 3,000 milligram, whatever here you get, you need to convert it to Q8. And that's how this proportion equation will work. You have to maintain the same frequency. Otherwise, if you try a different frequency, it's not going to be as accurate. So that was the fast way of doing it based on a single level. Another way to do it is to actually use population kinetics. So you can use the first order kinetic equation, C2 equals C1 times e to the negative k times delta t. So delta t is the time between the time of C1 and time of C2. Now, when you do get a single level, you only have C2. So you don't really have C1. So because you only have C2, you cannot really calculate the K. So although you have a level from the patient, this method is not truly individualized, because the only way to truly individualize the pharmacokinetics is to have two levels to actually calculate the K. Now in this case where you only have a single trough, now you have to estimate what that peak would be. So you can use this equation. So depending on the dose that the patient received, use the volume of distribution from population kinetics, and then the trough is the level that you actually measured in the patient. So use the dose that they got and the volume of distribution from population kinetics and the trough that you get to estimate the peak. And then based on this estimated peak, you can re-estimate the K. So previously you used the K from population kinetics. Now you kind of semi-individualize it because the trough is from the patient, but the peak is still estimated. So overall, this K is not truly individualized. And then you can recalculate the clearance based on the new K and the volume of distribution from population kinetics from before. And then once you get these new values, you can calculate new tau and dose using the old volume of distribution and the new K and the new clearance. Anytime you make a change to the dose, you gotta get a trough at the steady state. So anytime you change the dose, you gotta wait to get the level prior to the 4th or the 5th of the new dose. Because every time you change the dose, now the new regimen is not as steady state. So you got to give the new regimen time to get to a steady state. And of course, always before you actually adjust the dose and frequency of vancomycin, actually evaluate to see if the patient still needs vancomycin. Oftentimes, vancomycin is used empirically, and after a few days, it should be determined if the vancomycin needs to be continued or not. So oftentimes, if you actually evaluate the need for vancomycin, it might be that vancomycin is no longer needed, so your intervention would be to actually discontinue vancomycin. So before you spend time to figure out the dose and frequency for vancomycin, first evaluate if it's actually needed. Now let's take a look at patient-specific pharmacokinetics. This is when we actually get two levels in the patient in order to precisely calculate the slope of the line, which is the negative K. So the K constant. Now for this we need two levels. So the first level is C1, and we have to make sure that the C1 is drawn at least 2 hours after the end of the infusion. So this ensures that the level is outside of the distribution phase so that we get the slope of the correct line. Then we use the equation from first order kinetics to calculate K, and the delta t is the time it takes from C1 to C2. So T2 minus T1 will give you delta t. And then using this individualized K, we can actually calculate the true peak, because whatever C1 we get, that's not the true peak. The true peak would be impossible to draw, because if we actually draw a level at the end of infusion, it would be inside the distribution phase. So we have to calculate the true peak, and we can basically use the first order kinetic equations. We can also use this equation, which is actually a rearrangement of the same equation. You just have to make sure that you use the correct t. So the t is basically the time it takes from true peak to trough. So one way to calculate this t for true peak is to subtract infusion time from tau. You can also calculate the true trough assuming that C2 was not a true trough. If C2 was indeed the true trough, then there is no need to calculate it. And then we did all of this because now we can actually calculate the specific patient volume of distribution. So for this, we put the dose that the patient had received before drawing these levels, the time of infusion from that dose, and then 1 minus e to the negative k. So this is the k that we just calculated. Ti again is the time of infusion from the dose that the patient had received, and then we divide that by k times the true peak that we just calculated and the true trough that we just calculated times e to the negative k times t to time of infusion. So again, this is the time of infusion corresponding to the dose that the patient received before drawing these two levels. And then after we get this volume of distribution and the k, we also need to calculate a new tau. Now this is assuming that the previous dose was not giving us the levels that were at goal. And then you can recalculate the tau using the new k that we calculated. And then we calculate a new dose using the tau and everything that we so far calculated. So the new k, the new volume of distribution. And then for the peak here, we put the target peak from this table, and then negative k and tau. So tau will be the tau that we calculated here, and then 1 minus e to the negative k times ti. For ti, we can just plug in 1 since we don't know what the dose is yet. And then once we get a dose and a tau, it's important to make sure that it's going to give us the correct predicted peak and trough before we actually recommend the dose. So we will use these equations. Now, this TI should be a TI that matches the dose. So for example, if you have 1500 milligram, you should put the TI of 1.5, because remember, for vancomycin, we have to choose a infusion time that would avoid or at least reduce the risk of red man syndrome. So if you have a dose of 2000 milligram, then your time of infusion should be 2 hours. So you make sure that you use the appropriate TI, and then 1 minus e to the negative k. Again, this is the k that we calculated, and this is the same TI that you put here, divided by volume of distribution that was just calculated, the k that was calculated, times 1 minus e to the negative k times tau. So this is the tau that was calculated here. And then once you get the predicted peak, you use this equation to see what the predicted trough would be. And again, you use the tau minus ti. Again, ti has to match your dose. So whatever dose you calculated here, the ti has to match it. And then if you're happy with the predicted peak and trough, then you go ahead and recommend your dose and frequency. And you have to make sure that you specify the correct time of infusion, as well as when to give the next dose. So for example, if depending on why you're adjusting the dose, if the level was supratherapeutic, then you have to calculate how long it would take for the trough to go to less than 20, and then recommend the new dose to be started at that time. We looked at the PK/PD of vancomycin and determined the loading dose for vancomycin. We also use IDSA guidelines and population kinetics to determine an empiric vancomycin dose and frequency. We also selected an individualized vancomycin dose and frequency based on serum vancomycin levels. Now the next learning objective is, given a patient on intermittent hemodialysis, recommend appropriate vancomycin dosing and monitoring. Intermittent hemodialysis typically removes about 30 to 40% of vancomycin in a full hemodialysis session, which usually takes about 4 hours. Sometimes because of hemodynamic instability, hemodialysis sessions could be terminated early. So if a hemodialysis session lasts shorter, so let's say 1 hour, then less amount of vancomycin will be removed. Now, a lot of published protocols actually suggest to get the vancomycin level before dialysis, and then assuming that the patient gets the full dialysis session, then you can actually calculate and say that 30 to 40% of it was removed, and calculate what would be the trough after dialysis session. However, in clinical practice, most clinicians actually get the vancomycin level after dialysis. Now the issue is, when should you get the vancomycin level after dialysis? Should it be immediately after hemodialysis, or should you wait for a while? And this goes back to the two-compartment pharmacokinetic model of vancomycin. Because of tissue redistribution phase, it results in a 20 to 40% increase in plasma concentration. When vancomycin is administered, a good portion of it goes into the peripheral tissue, and the level that we get is actually from the central compartment, which is circulation. And when hemodialysis is complete, hemodialysis is basically removing vancomycin from the central compartment. So immediately after completion of hemodialysis, if you get the level, it will show the level in the central compartment, which is the blood, which might be low. However, if you give it some time, so about 2 to 3 hours, vancomycin starts to come out of peripheral tissue to find equilibrium between blood and peripheral tissue. So therefore, if you get a level immediately after dialysis, the level could be artificially low, and then 3 hours later the level goes back up. So it would not be a good idea to check the level immediately after dialysis. So it's recommended to wait approximately 4 to 6 hours after hemodialysis to wait for tissue redistribution to be complete, and then get a vancomycin level, which would be a better indication of what the actual true level is in the patient. So your institution might have a protocol to get the vancomycin level 4 to 6 hours after completion of hemodialysis. However, majority of evidence is with getting a level pre-dialysis. So the 2020 ASHP IDSA guidelines say that as hemodialysis membrane technology has improved over time, dialyzers have become far more permeable. So pretty much modern hemodialysis machines are basically high permeability dialysis. So they use high permeability membranes. So for patients receiving hemodialysis, the guideline recommends a loading dose of 25 milligram per kilo one time. And this is based on total body weight. And then they recommend a maintenance dose of 10 milligram per kilo thrice weekly, or this is 3 times per week. And this is because typically intermittent hemodialysis is done 3 times a week. So either Mondays, Wednesdays, and Fridays, or Tuesdays, Thursdays, and Saturdays are common. And this maintenance dose is basically to give this after the dialysis is done. And they do recommend getting a pre-dialysis instead of post-dialysis to get a pre-dialysis level. And as long as this pre-dialysis, so this is right before hemodialysis is done, if you get a level and it's 15 to 20, it's very likely to achieve a AUC of 400 to 600 in the previous 24 hours. And then this dosing recommendations are just to start things. Then, at least the weekly vancomycin pre-dialysis level should be driving the subsequent dosing of vancomycin. We looked at the PK/PD of vancomycin and determined the loading dose. We use IDSA guidelines and population kinetics to determine an empiric dose and frequency. We also looked at vancomycin levels to select individualized vancomycin dose and frequency. We also looked at vancomycin dosing in intermittent hemodialysis. Now the next learning objective is given a patient receiving vancomycin, approximate vancomycin AUC. So remember that AUC is for a 24-hour period of time. In this example, we're showing you a Q8 dosing of vancomycin. So on the horizontal axis, you have time. So it goes from time 0 to time 24. And on the vertical axis, we have vancomycin concentration in the blood. If you give this vancomycin dose 3 times a day, or Q8, so you get a peak 3 times. And the area under all of these would be considered the AUC for 24-hour period. Now, if you get a single level, if you get just the trough, the question is, can you estimate how much the AUC would be? So because the AUC is the area of under the curve, if you have a trough of 10, you can say that this level never goes below 10. So you can say that the area under the curve is at least 10 times 24, which is 240. So this area is at least 240. And then you also have all of these areas at the top, which we don't know because we don't know what the peak is. So that's the issue. When you only get trough, you don't really know what the true peak is. So it only allows you to estimate what the AUC is. So we know that the AUC is at least 240. And remember that we want the AUC to MIC ratio to be at least 400. So if the MIC happens to be 1, we need an AUC of 400. Now this highlighted area is at least 240. So we're hoping that all of these area at the top is at least 160 to add up to 240. So that's where the recommendation of goal trough of 10 to 15 come from. So in a non-serious infection, if you have 10 to 15, so of course if you have 15 times 24 will give you 360. So now 360 is close to 400, and of course we have all of these area at the very top. So I'm actually very confident that a trough of 15 will achieve 400. So for a non-serious infection, the old guidelines recommend a trough of 10 to 15, and they're saying that if you achieve a trough of 10 to 15, you probably had an AUC of at least 400. You can be confident. Now, if you have a trough of 20 times 24, it's at least 480. So you definitely have achieved the AUC of at least 400, because you also have all of these areas. So at the very minimum, you have 480 plus all of these. So a trough of 20 is an overkill. So you definitely achieved an AUC of more than 400. Now the thing is, if you do between 15 and 20, so 15 would give you 360 and 20 would give you 480. So for serious infections, they said if you target a trough of 15 to 20, you're basically guaranteed to have an AUC of 400, and that's where those recommendations are coming from, which in the case of 15 to 20 could actually be overdosing. Now let's see the correlation between trough to AUC. So these guidelines from 2009 and 2011 said that you can use trough as a surrogate for AUC, because we know AUC is the PK/PD target for efficacy. So AUC actually determines efficacy. Trough really doesn't mean anything for efficacy. Trough only is meaningful for safety, which we will talk about in a little bit. But for efficacy, trough doesn't mean anything. So what they said was that they're actually using it as a surrogate for AUC, which is the actual parameter for safety. And they said that's because there's a significant correlation between trough and AUC. And when they said it's a significant, what they meant was that this is a statistically significant. So in this graph on the horizontal axis, we're looking at the vancomycin trough, and on the vertical axis we're looking at AUC, and here you have a scatter plot, and then you can actually get a Spearman P and correlation coefficient. So the correlation coefficient, or R, is 0.43, which means there's a 43, or let's say there's a 44% correlation between trough and AUC, which is horrible. That's worse than a coin flip. So there's only a 43 correlation between trough and AUC. And if you get the coefficient of determination, which is R squared, is only 19%. So that means only 19% of variation in AUC is determined by trough. And the p-value for it was significant. So they said there's a significant correlation between trough and AUC. But nevertheless, it's not a very good correlation, because it's less than 50%. So what else can we do to estimate AUC if trough is not really a good surrogate for AUC? So one thing that you can do is use the general equation AUC equals dose divided by clearance. So especially if you have 2 levels and you actually calculated the clearance in the patient, you know the dose and you know the clearance, you can actually get the AUC. Now empirically, when you just starting the dose, you can't really know the clearance in the patient from levels, because you haven't received levels yet. So you can actually use population kinetics. So there's this equation, the Moyes-Brother equation, that was actually derived from their patient population, that can actually estimate what the AUC would be empirically. So imagine you wanted an AUC of 400 and you know the patient's creatinine clearance, you basically solve for dose, and that will give you the empiric dose that will give you the AUC that you want. Now, a better way to do it is to actually use the multiple levels that we got in the patient to use individualized pharmacokinetics to calculate the AUC. For doing this, we can consider two areas. So the first area is the area during the infusion phase. So AUC INF, this is the first area, so for one dose. And this is basically using a trapezoidal rule. So you can imagine that this is a trapezoid and you're calculating the area for that trapezoid. So peak plus trough divided by 2 times the time of infusion. So going from this point to this point will basically give you the height of trapezoid if you consider this the a flipped trapezoid, so to speak. And then you have the first base and the second base, which you can add together and divide by 2. And that will give you basically mathematically the area during the infusion. And then you need to calculate the second area, which is during the elimination phase, which of course also includes the distribution phase. But the AUC elimination phase is peak minus trough divided by K constant. And again, K is calculated from the two levels that we got from the patient. And then you basically add these two, so they will give you the AUC for one dose. And then to get the AUC for a 24-hour period, because this is AUC 0 to 24, you basically have to multiply by 24 divided by tau. For example, if your tau is 8, because you're giving the dose every 8 hours, 24 divided by 8 would be 3. So basically you multiply this AUC by 3, so that will give you the AUC for a 24-hour period. On the other hand, if you're dosing it every 24 hours, your tau is 24, so this basically gets canceled out. So these two areas will give you the AUC. Now, another thing that you can do, which is actually what the new 2019 IDSA guidelines are actually recommending, is to use the Bayesian approach. So now there are Bayesian software that are becoming pretty readily available and affordable. Bayesian software actually uses adaptive model that fits your patient with very high accuracy. And these models can either use a single level or it could use 2 levels. So using 2 levels is more accurate, but nevertheless, even a single vancomycin level is very accurate in predicting AUC. Bayesian approach actually uses the Bayes theorem. It quantifies the sequential relationship between the estimated probability distribution of an individual's patient pharmacokinetic parameters, so such as volume of distribution and clearance. And this is referred to as Bayesian prior. So the Bayesian prior basically uses population pharmacokinetics. So basically the things we did to calculate volume of distribution and clearance to estimate what the patient's volume of distribution and clearance would be empirically. And then once you get the vancomycin level, either 2 levels or 1 level, you put them in the Bayesian model, and then from these two, you get the Bayesian posterior. So it basically revises that probability distribution that was population kinetics to adapt the model to the patient. And this allows AUC estimation, and it is very accurate. So I imagine that over the next few years, more and more hospitals will adapt Bayesian software. There are ways to build this software into Epic or other systems. There are also web-based versions of Bayesian software that can be used. So over the years, we will see more and more of Bayesian approach being utilized. Now, one last thing that I want to talk about is vancomycin continuous infusion. So if you were to, with intermittent infusion, I showed you that you can estimate what the AUC would be from the trough. Now, if you do a continuous infusion, if you start from 0 and you infuse the vancomycin dose over 24 hours. So you basically increase the time of infusion all the way to 24 hours. So within 24 hours, you actually get to the steady state. So you go from 0 to 24, and then at 24, you get a flat line because you're continuously infusing it over time. So then you don't get the peak and trough. You just get the flat line. So if you get the level at any time, that level is a random level, but it's also your peak and trough. So if you were to get the level of 20, your area is, you're no longer estimating what the AUC would be. The the AUC would be exactly 20 times 24, which is 480, because you don't have the peak and troughs anymore. This is a continuous infusion. Now the problem with continuous infusion is during the first 24 hours, it took a very long time to get to this, so you were underdosing for the first 24 hours, which can be fixed by giving a loading dose. So if you were to just do the continuous infusion without the loading dose, you get this. If you do a single loading dose, that's the graph that you get, and then you do a loading dose and your continuous infusion, then you get this peak here, and then after 24 hours, you get a flat line. So that would be the best approach to get the right AUC. Now, however, there are advantages and disadvantages to continuous infusion. So advantages would be that it's effective PK/PD target attainment, potentially less nephrotoxicity because you don't get those high levels of vancomycin in there. You don't get those high peaks. It basically becomes once a day dosing because you're infusing it over 24 hours. So it's literally you change the bag every 24 hours. In fact, because you only do this every 24 hours and infuse it over 24 hours, this is oftentimes used outpatient. So it's convenient for outpatient parenteral antibiotic therapy or OPAT. Now the disadvantage is that a vascular line will be busy all day. So if you wanted to administer other antibiotics or other medications, really, a line would be taken. And ultimately, we haven't, studies have not shown a clear evidence of improved efficacy over conventional intermittent dosing. And the 2020 ASHP IDSA vancomycin guideline recommends continuous infusion may be a reasonable alternative to conventional intermittent infusion dosing when the AUC target cannot be achieved. So if you keep getting levels and you cannot achieve the AUC, then continuous infusion might be able to help you achieve those targets. If so, especially in critically ill patients, a loading dose of 15 to 20 milligram per kilo is recommended, followed by a daily maintenance continuous infusion of 30 to 40 milligram per kilo. And this is to achieve a steady state level of between 20 to 25 milligram. And this doesn't matter once you're at steady state. It doesn't matter if it's a random level because your peak, trough, and random are the same level. The last learning objective is explain the toxicodynamics of vancomycin based on serum trough and AUC. There are a lot of studies that have looked at the correlation between vancomycin trough and toxicity, specifically nephrotoxicity. So here on the horizontal axis, we're looking at different levels of trough. So less than 10, trough of 10 to 15, trough of 15 to 20, and trough greater than 20. And then on the vertical axis, we're looking at the rates of nephrotoxicity. So you can see that basically not much difference if the trough is less than 10 or 10 to 15. However, when the trough starts to go above 15, you start to see increased the risk of nephrotoxicity, which is highest when the level is greater than 20. So because the risk is greatest above 20, you should never have a trough of greater than 20 unless the patient is on continuous infusion. These troughs are only pertinent to intermittent dosing, so these numbers don't apply to continuous infusion. And of course, even 15 to 20 is still more nephrotoxic than 10 to 15, so more reason to avoid targeting 15 to 20. Now, this is a systematic review and meta-analysis from multiple studies, and they're looking again at the same groups. Trough less than 10, trough 10 to 15, 15 to 20, and greater than 20. And in the meta-analysis, specifically, they compared trough of 15 or higher versus anything that's less than 15 to see if it makes a difference. And so these are all the different studies that they have added to this meta-analysis. And then the sum of all of these studies shows that there is a significant increase in odds of nephrotoxicity with a trough of greater than 15 or greater than or equal to 15 compared to trough of less than 15. So, more and more evidence suggests that trough of 15 or higher is actually nephrotoxic. And there are many risk factors for nephrotoxicity. There are a lot of studies done, and they found that if the total vancomycin daily dose is more than 4 grams or 4,000 milligram, the patients are more likely to have nephrotoxicity. If vancomycin trough is greater than 15, which I just showed you, also if the vancomycin AUC is greater than 700, that's also nephrotoxic, and that's why the new guidelines are targeting an AUC of 400 to 600, because they don't want you to reach 700. Also, if the therapy exceeds 6 days, so if someone is on vancomycin for just a few days for empirically, and then you discontinue it, they're less likely to have nephrotoxicities. When patients have longer periods of time, that they're more likely to have nephrotoxicity. Also, concurrent use of other nephrotoxic agents such as aminoglycosides and piperacillin tazobactam, and also some antifungals like amphotericin B. They can be, along with, sometimes patients are on NSAIDs, for example, that can cause, that can be nephrotoxic. Patients who have pre-existing renal disease, and that's defined as serum creatinine at baseline of 1.7 or higher, or if their creatine kinase was less than 86.6. So these are risk factors. Obesity was also risk factor, and that's defined as total body weight of 101. The way they came up with these numbers, basically they've done logistic regression, and that's how they have come up with these numbers. They found statistically significant correlation between these and nephrotoxicity. The next one is hypotensive episodes. So for example, someone who actually developed shock as a result of the infection, they were more likely to develop nephrotoxicity. That could be in part due to shock results in hypoperfusion of the kidneys. So if the kidneys are not getting perfused adequately, they're more likely to see damage. And lastly, increasing severity of illness. So patients who are more ill are more likely to develop nephrotoxicity. So the longer someone is in the ICU, the higher the risk of developing nephrotoxicity. And lastly, since pretty much the old guidelines were targeting 15 to 20 for more severe infections, and I just showed you that 15 to 20 is more nephrotoxic than 10 to 15. They want to see, well, since we're targeting 15 to 20 for more severe infections, is 15 to 20 even more likely to achieve the AUC to MIC of 400 compared to a trough of 10 to 15. So they did the study, and they actually found that more, patients who had a trough of 15 to 20, they were not more likely to have an AUC to MIC of 400. So even though their trough was higher, they were not any more likely to have that AUC to MIC of target. So the new guidelines actually do not recommend a trough of 15 to 20 anymore. More and more evidence shows that 15 to 20 is nephrotoxic, and also 15 and 20 is not likely to result in better efficacy. So for most patients, 10 to 15 is sufficient, and really we should be targeting AUC to MIC in our patients for efficacy. This concludes this presentation.